Okay, very good afternoon and morning, evening, night to whichever countries are involved. Um, we shall start our inaugural D-Food webinar sessions, which was actually on for the last 2 years, 2023 to 24, 25, and this will continue all the way to 2027. Now, this is the new board members for 2025, 2027, basically with the president-elect as Salma, our past president is, and also honorary president is Prof. Abbas. And then Mr. Willem is the Vice President Finance, Ms. Jolene, Vice President from South Africa, Dr. Wahid, Vice President from Maldives, Dr. Lewin, Vice President from Philippines, and Professor Fran Game, the Vice President from England. And our nominating committee, we have Dr. Prof. Zahid here, and also Prof. Shige Kono from Japan. Thank you very much to the previous board and also to our past president, Dr. Abbas, and also the immediate past president at that time, Dr. Vijay, who has now also become one of the honorary presidents, and the whole team for 2023-2025. And also to all the regional chairs, regional advisors, country representatives, full members, who will all be basically, who already got their appointments for the next 2 years. Now, DFO International is a registered international non-profit association under Belgium law, and it is a global organization consisting of people working in the field of diabetes-related food care. All are dedicated to providing food care. These people are spread across 7 regions. We are following the IDF guidelines, which is the 7 regions in the world. And we have board members, regional chairs, and advisory, and country representative, and full members from all these 7 areas. Our mission is to promote the global profile of diabetic food prevention and care through awareness, guidance, education, research, and professional development, and ending avoidable lower limb amputations due to diabetes worldwide. And we are the implementation arm of the IWGDF, and I'm happy to say that with Professor Fran Game, who is the chair of the IWGDF, who is actually one of the vice presidents of DFO International, we are now what they call is a close-knit society. And our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. And this brings us to our session today, which actually is going to show some of the cases where we have got difficulty managing it. So our focus of action is to train healthcare professionals with different causes, manage diabetic-related food problems, give healthcare professionals strategies to implement, develop, and sustain food services, whereby we have given a grant to one of the consultants, one of the specialists basically from Indonesia. And we also have to promote the recognition of diabetic food specialists. So to close the gap of available and affordable diabetes food care, especially in low-income, middle-income countries, and strengthen also the developed countries. Now, this is some of the activities that was done in 2020-2025, which are being continued, which is your train the trainer, food healthcare professionals. And then this is continued basically from 2025 onwards until 2027. And our World Diabetes Day Awareness Week, which will be changed to World Diabetes Day, basically. So one day, what do you call this, for all the 7 regions. Now, there are multiple, what do you call this, the implementation programs, basically webinars, newsletters, brochures, leaflets, and more, cost studies, Aphrodite project, fast track projects, step-by-step food projects, and also training for the surgeons. These are the many partner organizations that we shall increase, basically. Professor Bieta and team is also trying to do more work with the EU. These are other partner organizations around the world, right? So we have already 20 basically, and continuing. Our flagship program basically is for the healthcare professionals. You can see SACA region, Western Pacific region, Europe, Sub-Saharan Africa, and MENA region. And this is the 8th session, basically in SACA, 9th in the Western Pacific region in Malaysia, and then 10th basically in Europe, in Slovenia, 11th basically in Africa, in Zanzibar, Tanzania, 12th in the MENA region, basically by Prof. Zahid and team in Karachi. And our World Diabetes Week, basically, which was actually run in 2023 in the 7 regions, basically, with 54 specialists. Then 2024, basically, and with 61 specialists around. And the Diabetes Awareness Global Day, basically, all right, on the 16th of November 2025. Now, this will be basically all those regions will be having this on the same day. So we found that this is the best time basically to have all one shot instead of 7 different days at 7 different timings and all that. Now our webinars on Saturdays is continuing. And this is the first webinar on the hardest wound, a real-time case study. So we have named it as Sherlock Saturday, basically following Sherlock Holmes style, so to make it more innovative and more interesting in the sense. We have newsletters, basically. Dr. Raida here basically is continuing as one of the sub-editors of the newsletter. And we have our multiple brochures, which will continue. Leaflets, basically, in 2025. All right, these are all the leaflets in terms of Charcots, in terms of diabetic foot and all that. Now, research-oriented projects is very interesting, basically, because we are continuing with the studies and all that. And I think Keaton, I just met Keaton basically in Singapore for the DFCon and the Asian Society of Vascular Surgery meeting. So he was one of the ones with Abbas and the teams and all of us in the 7 regions who talked about standardized diabetic-related foot ulcers of different severity. So this cost study was quite good. And one of the aspects that we're actually moving into is our past president, basically Professor Abbas, will be leading the research wing of DFO International, whereby basically with the Afro-Dial and then the Asia and Afro-Asia Dial and all the other groups, basically, we expect to do more what do you call this, research-based projects, especially so if you look at in 2011, the IWGDF, they actually found that every 22nd a foot is being amputated. So the next project that we are undertaking is also to look whether it is still the same or it is actually worsening or it is getting better. So from the outcome of all these courses, basically over in SACA, Western Pacific, Sub-Saharan region, we find more what they call healthcare professionals who are interested. And then we actually publish in the Global Wound Care Journal, which is the journal of the World Union of Wound Societies, where DFO International was actually, we actually joined as a supporting society. So myself and Abbas wrote for what they call this DFOOT at that time. So we're expecting more publications for this. And then with the Aphrodite, basically from 10 countries, another publication, and it will also be presented in the EASD meeting. Now, on the 8th of October 2025, we are doing a consensus document on the implementation strategies for the prevention and management of diabetes-related foot disease, DFOOT 2026 update. So this will be launched. After that, it will be actually one of these projects that we're doing with the UK, with Wounds International, and the whole board plus a few regional chairs and all that will also be involved in this, up to about 12 different countries coming in to actually do this consensus document, which will be held in Sunway Pyramid in Malaysia. And then the 4th conference basically will be held in Maldives from 1st to 3rd of May. Right, so Dr. Wahid will be actually doing that. So we've moved from different areas, basically from Malaysia, Mumbai, and then back to Borneo, and then from Borneo to Maldives. All these panelists basically will be from our ranks. And with that, we start basically our webinar for today. Okay, and total registrations about 210 delegates from 58 countries and is increasing. This webinar today basically will be presented by Professor Abbas on the hardest wound, a real-time case study. Professor Abbas is actually the past president and also the already president of DFO International, a consultant physician, endocrinologist, and diabetologist, and a very close friend. He's basically from Dar es Salaam, Tanzania, and he'll be presenting basically today's inaugural session for the next 2 years, where we will go through all the 7 regions with different specialties and all that. And he's also a founder member of the Step by Step project, which has been implemented in about 128 countries. So with that, what do you call this, Prof. Abbas, I give you the floor. Thank you.
Thank you very much. I start with the name of Almighty God, who is most gracious and merciful. Again, good morning, afternoon, or evening to all, wherever you are in the globe. Salams and greetings to you all. I feel extremely honored and privileged to start the first webinar program during this term for the years 2025-2026, thanks to the board and Harry. We have designed all 7 webinars according to the region, and each specialist will come and talk on specific specially oriented to this patient, which we'll start today, presenting today. I have, for the sake of easiness, I have recorded my talk to avoid the hitches of internet as we are in sub-Saharan Africa. So let us start my recording, but I'm around. Zaima, can we start? Yeah. Thank you very much. Thank you. I start with the name of Almighty God, who is most gracious and merciful. Good morning, afternoon, or evening to you all, wherever you are in the globe. Salams and greetings to you all once again. As has already been mentioned, we are starting a case series starting from sub-Saharan Africa regions, the hardest wound, and then will be followed by other speakers in next 3 months, every 3 months on a Saturday. I come from Dar es Salaam, Tanzania, which is the east coast of Africa. It's a land of Mount Kilimanjaro, Ngorongoro crater, largest game park, Serengeti, Zanzibar, Stone Town. You are all welcome. It already been mentioned, it's a Sherlock, which is a case presentations will have been started with me, a real-time case study followed by surgical approach and physician on a limb salvage and vascular limb revival by Dr. Salma from MENA region, and then from Western Pacific region, Professor Harry, about wound care strategies. Objectives: at the end of this session, healthcare professional will be able to provide better care for people with diabetes-related foot complications, prevent the number of foot and limb amputations, prevent mortality with diabetes-related foot complications, reduce the patients and healthcare burdens of diabetes-related foot complications. As we know, the global population um, from Asia and Africa are the two largest continents in the world. Asia and Africa combines about 6.3 billion, which is 77% of populations, and 80% of diabetes come from this region, whereas the rest of the world is less than 2 billion and 23% of population. So we have a huge burden of diabetes in next 20 years. If you look at the latest results of diabetes prevalence, which were released in April 2025, and we can see Africa is leading by 142%, followed by MENA region, and then Southeast Asia. So this, this combines Africa and Asia. Look at Africa, where we were 20 years ago, which was 7.1 million, now around 25 million, which was done in 2024 last year. And next 20 years, we are going to lead by 60 million, which is an increase of 142%. The prevalence of diabetes is increasing globally. The greatest increase will occur in sub-Saharan Africa. Increase is associated with rapid demographic, socio-culture, and economic transition. We are rapidly developing with increased affluence due to urbanization, shift in lifestyle, demographic transitions towards an older population, elevated risk factors such as obesity and physical inactivities, and that are closely associated with increased prevalence of diabetes. So we are developing at the cost of health. As we go increase in diabetes, the complications are also going to increase: diabetic retinopathy, nephropathy, stroke, cardiovascular disease, and diabetic foot, which we are going to discuss today. Sorry. Diabetes-related foot complications. Worldwide, there will be increase in prevalence. I've been talking about it. Parallelly, the foot complications are also going to increase. It's a major public health problem. Main cause of hospitals admissions. Cost will not be sustainable by the family and in large the nation. Commonly in our setup is an infectious etiology associated with peripheral neuropathy and arterial disease. Just let us look at the overview of diabetes foot ulcers in African continent in past 60 years, and you can see that diabetic peripheral neuropathy is similar to what we see in the Western world, 5 to 80%, and all over in Africa, it's the same rates. Major underlying risk factors for ulcers and infection in our cases. And look at this: in last 10 or 20 years, the diabetes prevalence is similar to wherever you are in the world. when we did a study from African and Asian patient, the similarity was also seen whether you're an African patient or Asian. The peripheral neuropathy was similar and there was no difference. Looking at arterial disease, where now we are almost in double digits wherever you are in Africa, which is almost similar to what we see in the Western world. And uh, even if you go past 20 years, it is increasing. But before 1990, when you look at that, the prevalence was actually in a single digit. So we have actually really increased the prevalence of diabetes, peripheral arterial disease, due to at the cost of development. And similarly, arterial disease was not significant whether it was in African or Asian patient, which we did a study back in 2009. And even the neuroischemic combination of arterial disease and peripheral neuropathy. This was back in early 2000, 2003, where we did a Caucasian population from Germany. My friend Mobek took part, Tanzanian myself, and Dr. Vijay Vishwanath from India. And you can see peripheral neuropathy, there was no difference wherever you are and whatever population was from Africa or Asia or Europe. But in peripheral arterial disease at that time, Germany, it was significant compared to Tanzania and India. So it clearly shows that now rates are increasing. Amputations in patients with diabetes, gangrene and infections are the most common. True prevalence in low and middle income countries remains underestimated, and reports usually shows that delay presentation is the main cause of amputation, and most of the patients who need surgery die even before intervention by the surgeons. We had estimated when it was a diabetic foot year, which was every 30-second a limb was lost, but in 2017 we re-estimated and it became to 20 seconds due to diabetes. And now it has been assumed that it has gone further back to worse. So all these seminars, conferences, hands-on workshops, all this, after all doing this, still the amputation rates globally are increasing. Outcome study in the national hospital, you can see that 33% of the patients underwent amputations, 54%, more than half, died due to leg presentation, and overall mortality in this patient was 27%. And it is similar everywhere in the world. Wherever you go in Africa, the amputation rates are in double digits and high. Diabetic foot wound in Africa regions, and these are the hardest wounds where we see everywhere in sub-Saharan Africa, and day in and day out, every day we see this is the wound still presenting to our center. The cost obviously is going to increase, and we just did it published this year in April, diabetes related foot complications treating the cost in 7 regions of the world. And this is the paper which was published recently, and you can see only, I'm going to talk about Africa, the mean cost of treating the wound was almost 2,400 USD dollars, which was equivalent to 0.06 cost of America. And average annual salary of African patient from sub-Saharan is about 1,100, and which is almost equivalent to 30 average time to cover the cost. That is a salary of 30 months. So you can see if there is one bread earner and 10 people is been extended family in Asia and Africa, it's a huge burden to the family and at large to the nation. Now let's come to the real-time case. This is a patient presented to us, ZSN, 59 years old housewife from city of Dar es Salaam, Tanzania. He had a history of diabetes for 5 years and on oral hypoglycemic drug but was not regular. Main complaint was an ulcer on her left foot. Lesion started 2 weeks ago, reported to the local doctor a week ago. Fungal infection, she mentioned it was started as a fungal infection between 4th and 5th toe. and patient was booked for below knee amputation. So she came to us on 19th July 2023. What should we do for this patient? So I will go as we go along and we start solving this patient, this case. Clinical diagnosis: on journal examination, there was fever, tachycardia, heart, high pulse rate, high respiratory rate, and the mental status was altered of this patient. On local examination, it was infection grade 4, which we are going to discuss as we go along. Skin discoloration, as you can see in the picture, sweet odor, discharge, ecchymosis, and blisters or hemorrhagic bullae. What are the risk factors? So now we're going to palpate the patient, and the risk factors could be peripheral neuropathy, peripheral arterial disease, or neuroischemic lesion. Risk categorization according to the international consensus: grade category 0, loss of protective sensations in peripheral arterial disease. So there's no loss of protective sensations of peripheral arterial disease. Grade 1, category 1, either one of them would be present. Grade 2, both of them plus deformity. Or grade 3, previous ulcers or amputation. So in our patient, on local examination, there was severe peripheral neuropathy. Pulses were palpable, bounding pulses, severe pain on palpations, tenderness, and swelling of the leg. The last option, I have left it open to think what else we can find, and I'll answer this as we go along later on. Coming back to the patient, is this lesion infected? Yes, we will all agree this is infected. So according to the guidelines, if it is infected, then we have to assess according to using the IWGDF or IDSA classification scheme, which has been strongly recommended, and a classification system for defining the presence and severity of infections. No clinical signs of infections locally, that's grade 1, uninfected. Superficial lesions with at least 2 of them should be there. So that's a grade 2 of mild infection, local warmth, local tenderness or pain, local swelling or induration, erythema more than 0.5 but less than 2 centimeters around the ulcers, purulent discharge, and other causes of inflammation of the skin must be excluded. So that's grade 1 and grade 2. Coming to the grade 3, that's moderate infection. Erythema would be more than 2 centimeters, and in most of the cases in our part of the world, we see more than 2 centimeters, and any one of the above finding, that means what we mentioned in grade 2, any one of them, plus involving the deeper structures beneath the skin. So it could be deep lymphangitis or osteomyelitis, and if it is osteomyelitis and involve the bone, so then we add in the bracket 0. That's osteomyelitis. I have written there here, refer the patients and do not delay. This is for low and middle income countries. When they see this type of patient at the primary district or regional area, and if they think they cannot go ahead, then they should refer same time to the specialized or national referral hospital. And there is no systemic inflammation, so the patient is not in septicemia. Recommendation 2, according to the guidelines, says that if there is a severe infection, then we have to admit it, and if there is a moderate infection, which we have already discussed, is associated with comorbidities, then the patient has to be hospitalized. So what are the criteria for severe infections? Grade 4 severe infections, that patient is in septicemia, at least 2 of them should be there. Temperature, high temperature, it could be high or low because of diabetes. Pulse rate would be high, respiratory rate would be high. WBC count could be high or low because of diabetes, and 10% immature leukocytes. There may be bone involvement or not, and if it is there, then we add 0 in the bracket. So that's grade 4. 3 most important clinical categories of infections. The list is cellulitis. Then we have those deep soft tissue infections involve the fascia and muscles, and then the bone involvement, that is osteomyelitis. The cellulitis is the most common foot problem where you do not need a surgical debridement, and it characterized by erythema, swelling, heat, and lymphangitis. In these patients, it was because of a Muslim patients and it developed a callus formation because of the prayers. Deep soft tissue infections involve the deeper structures. Necrotizing may be life-threatening, and debridement can be life-saving. Osteomyelitis is a spectrum of osteomyelitis haunts both the management of diabetes foot ulcers. Both layperson and healthcare professionals, they get what osteomyelitis is one of the end stages on the path of amputation, but it is not an indication of amputation. How did it get infected? And I had already mentioned initially, it started with the lesions between fourth and fifth toe, and it was tinea pedis, as mentioned by the patient, fungal infection, and we could see what investigation I should do with this patient. So obviously you're still in the clinic and the patient is presented, so the blood test would be done. So WBC was done, white blood counts it was high, erythrocyte sedimentation rate was high, CRP was high, and HbA1c, obviously patient was not controlled, it was about 14%. How do I diagnose and treat osteomyelitis? So the following used as an initial test to diagnose osteomyelitis of the foot in a person with diabetes. Consider using a combination probe to bone test, X-ray, and and the blood test which we already mentioned, and we can see this one of the patient where it was been cleaned superficially, and it was so delayed that patient developed a pathological fracture, leading it clearly shows involvement of the bone. And recommendation 7, according to the guidelines, says the same thing which we have mentioned: probe to the bone test, plain X-ray, and blood test. So this is initial study to diagnose osteomyelitis of the foot. If need arise, then you can go for MRI, but depending on the patient setting, advanced imaging for diagnosis is not needed in most of the patients, and that's a recommendation 8 according to international guidelines. Recommendation 10, if there is a suspicious of osteomyelitis before or after treatment, then we can consider taking the sample of the bone for culture. So in our patient, coming back to our patient, we did a X-ray examination, and it was done on same day on 19th July 2023, and you can see what we found was crepitus in the X-ray, and always obtain a proximal X-ray, and you can see the extents of the gas bubbles which were there. And this was exactly what I had left initially on local examination. And when we did is that painful crepitations, gas bubbles, creps were felt on palpation below knee joint. Should I culture the wound? And everybody would agree that we need to culture this wound. So how should I obtain the specimen? So that's another question will come when you are in the clinic. So recommendation 5 says that consider taking the culture, but it has to be taken as a deep tissue biopsy. So after wound has been debrided, take a deep biopsy from the base of the wound, and swabs are actually not recommended anymore, but if there is no option and if you want to take, then that's another thing. Consider obtaining the blood culture if patient is toxic, like in our case, or a bone culture for patient with osteomyelitis. What are the likely pathogens what you would see in these cases? So initially, these are gas-forming organisms. Do not wait for the results of culture and sensitivity. We need to start treatment. Infectious Disease Society of America, so it defines that Clostridium species, which are as follow: Clostridium perfusum, which is most of the time 90% of the cases. Then other Clostridiums are rare Clostridium also can be part. So these are other rare organisms which can also be found to some extent causing gas forming organisms. So infectious gangrene, which include gas gangrene, and these are gas gangrene and necrotizing fasciitis. Gas gangrene is a life-threatening infection. It is severe, fast-spreading bacterial infection, develops in hours to weeks. Primary cause by, as already mentioned, 90% Clostridium perfusions that destroys deep soft tissue and muscles, producing foul-smelling gas within the body. Mortality from non-traumatic gas gangrene ranges from 67 to 100%, so the action has to be taken, otherwise we will lose the patient within 48 hours. It's a medical emergency, results from a deep wound or surgery where bacteria multiply due to the lack of blood supply, releasing the toxins that causes tissue death and systemic shock. The virulence of organism depends on exotoxin produced by Clostridium perfusions, and there are known about 17 known toxins, with it the most toxic being the alpha toxin that breaks down the ulcer cell membrane, triggering the platelet aggregation, thrombosis, and histamine release. Toxin caused by direct vascular injury and breakdown of leukocyte, causing blunted post-inflammatory response to the infections. Symptoms include, which I've already mentioned, but just briefly: severe pain, swelling, skin discoloration, cracking sensation from the gas under the skin, and systemic symptoms. And I already said that early diagnosis and aggressive treatment of the gas gangrene are the key to decrease the mortality. Because the infection is rapidly progressing, it is important to treat the patient aggressive with antibiotic, early surgical consultation with debridement, intravenous fluid resuscitation, and obviously she will need an ICU monitor. Getting early surgical consultation without delay is important, and this is a true surgical emergency. Providers should not delay starting antibiotics, and then we can always follow up later on. Treatment requires immediate surgical removal of infected tissue and high dose antibiotics. Causes and risk factors: obviously in our case, underlying health condition and diabetes are very much prone to this because of weakened immune system, are at higher risk. Bacterial infections, primary, as I already mentioned, Clostridium species, and most common perfusions being the most common. And injury or surgery occurs in deep traumatic injuries or surgical wound where bacteria can live in low oxygen environment. So, take home point for the gas gangrene forming infections are caused by wide variety of organisms, the Clostridium species. Prompt diagnosis and management includes surgical debridement of all necrotic tissue, and this is an important to improve the outcome. Coming back to our patient, are any surgical procedure needed? Yes, I already mentioned, and we can see that same time it was sent to the surgeon, and the patient came back on 25th July as an outpatient treatment. And we will hear more on surgical approach after physician on limb salvage and vascular limb revival by Dr. Salma from MENA region on 6th December 2025. Should I prescribe antibiotics? Yes, everybody would agree that we need to start antibiotics. So IV antibiotics, broad spectrum antibiotics combination covering both aerobes and anaerobes, and obviously already mentioned about the surgical. What antibiotic should I start? So that's always the dilemma: what antibiotic should we start when we see this type of patient? And here you can see on your right side, as we go on, there will be a follow-up. This was on 17th August 2023. So what antibiotic should I start, and how should I modify the therapy once we get the results of the culture? So empirical general principle is we should start empirical choice, initially broad spectrum if necessary, based on clinical picture or a previous culture which has been shown in that area, and consider the commonest local pathogens antibiotic sensitive. Make sure all the infection should be covered for starting this type of patient: Streptococcus, Staphylococcus, E. coli, Proteus, Pseudomonas, and Klebsiella. And later on, we can narrow on once we get the culture result. Route of therapy of antibiotic: tropical, few data for only mild superficial infection we can start, but not been adequately studied. So it's an open, untapped research to be done on tropical treatment. Oral, well supported for most mild to moderate infection. If appropriate agent, then or no GI problems, then we can start IV. If there is no not competent to the patient. And parenteral, obviously, at least in severe infection, we should start or where there is no other oral agent. And same recommendation, which is strongly recommended and highly in the literature, systemic antibiotic regime effectively in published randomized controlled trial, dosing treated with person with diabetes and soft tissue of infection. So we have to start that, select the antibiotic likely proven, what we know, what are the pathogens and the antibiotic susceptibility. That's recommendation 13. Pseudomonas infection in our setup, we need to start if there is a severe infection, like in our cases, tropical or subtropical, but in temperate climate, maybe we can start after the culture if it is shown that there is a Pseudomonas infection. So that's a recommendation 15. We cannot start in tropical, in temperate climate, empirical treatment for Pseudomonas. There are factors which may influence the antibiotic choice. There's infectious related and organism related. Infectious related, clinical severity of the infections. Previously have been taken antibiotic maybe within 2 weeks. Bone infections presumed or proven. What is the status of the vascular in the infected site? Organisms, etiological agents known or maybe presumed. Local antibiotic susceptibility data if it is there. Then we have patient related, if it is an allergy to antibiotics, host immunological status, patient preference, renal or hepatic insufficiency, or there is a GI absorption impairment. Drug related, safety profile, frequency and severity, drug interaction, frequency of dosing, formulary availability or restrictions. Cost is very important in sub-Saharan Africa, approval for indications, and what are the published data about that. This is a selected guidelines which can be used as a selective characteristics of antibiotic that may be approachable for diabetes foot infection. And I will show that if it is +4, that's highly reactive to active to this agent, grade 3 moderately, +3 moderately active, grade +2 some active, +1 little active, and 0 is no activity. So if you look at it, the penicillins, we can see that penicillin G is very active to the streptococcal. Here we have a Staph aureus, streptococcal enterobacteria or anaerobes. And if you see the anti-staphylo and streptopenicillin, cloxacillin, diclocloxacillin or flucloxacillin, you can see it's very active to Staph aureus compared to other. And broad spectrum penicillin, ampicillin or amoxicillin, clavunet. And amoxicillin or penicillin, you can see is very effective, +4 in streptococcus, whereas amoxicillin and clavunet, which is very commonly used, is very effective to both staph and streptococcal. And to some extent, even it works with anaerobes. Anti-pseudomonas, the most effective which commonly used is piperacin and tazobactam combination, and you can see is highly effective in pseudomonas, staphylo, entero, and even working with anaerobes. Actually, all of them are effective, but most commonly used is piperacin tazobactam. And cephalosporins generation, first generation, second or third or fourth generations, they are also very effective, and especially if you start with IV initially and then going back. So it's mostly effective in staph and streptococci compared to anaerobes. Aminoglycoside is most focusing on the enterobacteria, which will not be effective in our part of the case. And fluconolin, ciprofloxacillin is slightly very effective again, enterobacteria. Then antifolate, saptrin, okay, to some extent, and metronidazole, which is this is the only item which has been highly effective in anaerobes. So we can do combination of any broad spectrum antibiotic with metronidazole. These are the proposal of empirical antibiotic therapy according to the International Working Group. And what I just presented you in summary is exactly what is here. In mild infections and more, we can always go back to read gram-positive cocci or gram-positive plus gram-negative rods, and you can see no complicated features, recently antibiotic exposure, high risks of MRSA. So, and accordingly, you can choose potential empirical regimes. Moderate to severe infections, no complicated features. We can start with a amoxicillin clavulanate or ampicillin sulbobactam, or second or third generation. Recent antibiotics, there's a choice here. We can macerated ulcer or worm, which is presence of pseudomonas, and you can see these antibiotics is similar, which I just mentioned you in summary. If there is a limb ischemia, gas forming, like in our case, then exactly what we mentioned can be started in summary just recently, just in the previous slides. And MRSA, Staph aureus, if it is suspected, then we can start with this potential empirical regime and risk factors for resistance gram-negative rods. Coming back to our patients, and now we have actually reached on the 24th of February 2024, and we can see the progress. So how long should I treat this patient? So that's always when you are in the clinic becomes in the mind. So soft tissue infection, mild infections 1 to 2 weeks, moderate to severe infections 2 to 4 weeks for most. Discontinue when clinical evidence of infection has resolved. And exactly recommendation 12 tells us the same thing for the soft tissue skin or soft tissue infection, duration of 1 to 2 weeks, and it's strongly recommended by the board and highly seen in the literature. Surgery, consider removing any infected or necrotic bone if possible. Antibiotic, all infected bone removed for 1 to 2 weeks, and if not, then it can go for more than 4 weeks, preferably 2 weeks IV. If no surgery, some data supports prolonged antibiotic for 6 weeks, and long duration of follow-up is needed in these cases of osteomyelitis. Recommendation 12, according to International Working Group, says continue treatment for 3 to 4 weeks if infection is not improving and resolving, then we expected slower than expected, or if the patient has a severe peripheral arterial disease, so we can continue for another 3 to 4 weeks. Well, recommendation 12D says if evidence of infection has not resolved after 4 weeks of appropriate therapy, re-evaluate for the patient for further diagnosis and alternative treatment. Consider duration of up to 3 weeks of antibiotic after minor amputations of diabetes-related osteomyelitis, and 6 weeks if there is no bone resection or amputation. That's recommendation 16. Recommendation 18, which is similar, applies to our patient. Urgent surgical consultation should be obtained in case of severe infection, necrotizing infection, or gas gangrene, signs suggesting a deep abscess, compartment syndrome, or severe lower limb ischemia. Consider performing early surgical within 24 to 48 hours with severe to remove the infection and necrotic tissue. That's recommendation 19. And recommendation 20, in a patient with diabetes, peripheral arterial disease, foot ulcers, or gangrene with infection. Here we need surgical specialty consultation by surgical specialties as well as vascular specialty, and it has to be taken care by them. That's recommendation 20. Coming back to our patient, what should I do for tropical treatment, wound care? We'll hear more on 7th of March next year by wound care strategies by Professor Harry, our president, and he's going to go more how to approach the wound care. But in summary, just give you a few couple of slides. Tropical treatment, which dressing to choose, and it's always confusing when what to do. So simple is as good as versus complex. Some basic principles need to be applied. It is not what you put on the wound, it is what you take off of the wound. So keep it simple, sweet, and this is the best policy wherever you are in the globe. Time frame. It is very important time, tissue management, infection and infection control, moist control, and ages, epidermal, and educational control has to be taken care. So moist wound healing, 50% of the fastest re-epithelialization in patient thickness of acute wound. uh, Benefits of the moist wound is wide variety of new materials have been developed and can be classified, and there are many in the market, but the moist wound has been shown to be better than other. So you can see moist control benefits of the maintaining the moist wound bed. So which dressing to choose for the tropical treatment? Criteria for ideal dressing: to remove the excess exudate and toxic components from the dressing, to maintain high humidity at the wound and dressing interference, to allow gaseous exchange, to provide thermal insulations, to protect from secondary infection, to be free of particles or toxic components, and to allow removal without trauma as the dressing changes. Importance of basic food care should never be forgotten. So metabolic control, it's very important. That's glucose control. Infection controls, antibiotics. Vascular has to be done, peripheral arterial disease. Regular wound control, debridement. Mechanical control, offloading if it is on the plantar. And most important, which is forgotten, education control, prevention. What is the expected outcome in our patient? And you can see this is now 22nd March 2024. So we can have the follow-up of this patient. Time to healing, long recovery, and compliance of the patient is key to have a better outcome. So where we started, and we saved this foot from below knee amputation, then almost patient is healed now, and she is working and walking. Prevention, which is mostly forgotten. Where do we go from here? In summary, many reasons for poor food in various less developed countries have been discussed. Increased high technology, rocket or molecular genetic science will not change the practice of diabetic food in developing world. If we have to ask what will change the practice of diabetic food in next 25 years, the reply to that question is not high technology, but rather dissemination of knowledge. In two distinct areas, this may impact as seen in the work done. Powerful tool for prevention and control of food complications in low and middle income countries, and it is empowerment of healthcare workers. If I've given you too much information, there's a last slide and you don't know which way to go, then the last slide which you can take the message home. Take home message: how to prevent food problems, and these are the 5 pillars of diabetic foot. Regular inspection and examination of the feet of the patient. Identify which are the high risk feet and categorize and look them more frequently. Education of the patient, family and healthcare workers, and most important, the ones which are on the high risk foot. Appropriate footwear, which is mostly not taken care in low and middle income country, has to be taken. And treatment of non-ulcerative pathology, like in our case we saw tinea infection. If it would have been taken at earlier stage, that stage would have not come. In conclusion, efforts are still required to increase awareness of diabetes and its complications among the healthcare workers and patients. Early detection and treatment of diabetes will improve the course of disease and reduce morbidity and mortality. And as we already mentioned again, now this case will be taken more further by Salma, and where she will going to look into the surgical approach and after physician on limb salvage and vascular limb revival on 6th of December. And then once she is done, and if the patient will come back to the wards, and then we have what are the innovative of the wound care strategies, where Professor Harry would go more deep into the wound care strategies. So this is my last slide, and I always quote this from from Holy Quran chapter 5 verses 32. And I always say that we are so lucky to be in this field. And what does it say? Save one life, you have saved the whole humanity. Knowingly or unknowingly, how many lives we are saving every day, and the credit which you get. Kill one person and it would be killing whole humanity. So if you save one life, you save the whole humanity. And the whole humanity, I just saw on September 4, stands at 1.2 billion. That is the credit you get for saving one life. But if you kill one person, that is the curse you get from the God by killing one person. Thank you very much. Thank you.
Thank you very much, Abbas, for a wonderful talk. And it's always nice, basically, when you're looking at real world evidence. I think previously everybody was talking about evidence based medicine by David Sackett's, and then after that, evidence based practice. But nowadays, everywhere in the world, whenever you meet people, it's always talking about real world evidence. I mean, sometimes it's a bit more difficult to go to level one evidence only, like the IWGDF. So it's good to actually see cases so we can know how it goes. I think the first session I would like to invite from the panel, maybe uh, any questions for Abbas? I think Milan has one. Role of antifungals in DFI. Should you use it empirically?
Yeah, very nice lecture, Abbas sir. I would like to ask you about do you use antifungals in all your patients, or you wait for the culture reports, which are very expensive, especially in India? Fungal culture is expensive.
Thank you. Usually, if there is clinically fungal infection and you can confirm it clinically, then I do start oral medications and also local applications. Like in this case, which we discussed, if this would have been taken care earlier, then it should have not reached to that stage. And this is, I mean, you can confirm it clinically. There is really no need to go through doing all these cultures or scraping of this or this thing. It's done. And I also published one of the papers, how high mortality is there due to amputation because of neglecting fungal infection. And it's more common in our part of the world, tropical and humid climate. It's very common. So we need to check between the toes. Thank you.
Thank you.
Timur?
Good morning, everyone. Wonderful lecture, Dr. Abbas, as usual. Two questions. What members of the multidisciplinary team were you able to use for the healing of this wound? And number two, was there a cost attached? Did you do a costing for this healing of this wound?
Okay, first I heard you that what multidiscipline we used for this. Almost all the multidiscipline we used, whatever is commonly used, though we don't have a podiatrist, but we did use the physician, surgeon, wound specialist. We also used for rehabilitation. And so everybody was involved. What was your second question?
Did you have a costing for approximately how much it would have cost from the beginning to the 2024 on average? Because obviously one of the things I guess I wanted to get across is the importance of the team, and the importance of the fact that yes, there's a cost attached, but it is over a period of time and it's worth the value of a life. But it'll be interesting to know the cost and how, because sometimes with these patients as well, everyone's not in the same location. So they may have to go somewhere else to get a vascular assessment or etc. So it's just interesting to know from your perspective and in your area how a patient like that will be managed, if it's under one roof or if it's across different multiple locations.
Yeah, thank you. We have done two studies. One was published in 2012, where 5 countries were involved, and recently we got published in April this year, where about 52 centers worldwide, 36 countries got involved. And I presented here the cost. We had 2 cases. One case number 1 was simple peripheral neuropathy, but this was the second one, which you saw how complicated it was. It costed about according to that paper, we did not follow up this, but that paper I will quote you, which was just published this year in 2025, where everything what you are asking me, evaluation of leg and peripheral arterial disease and everything, it costed about 2,400 US dollar, and it was almost 30 months salary for a bread earner in sub-Saharan Africa. That's an average cost.
Thank you.
Thank you.
Zahid, you have the floor. Thank you.
Hi, Abbas,
Hi.
excellent talk. And
Thank you.
as usual, you covered every aspect of this practically. And I think this is the dilemma of this part of the world, in the sub-Saharan region, Africa, and in the Asian region like Pakistan, India, Bangladesh, Sri Lanka, that we are having more and more infection, and they are getting more and more severe as they come to the clinical practice. The important thing is how to deal with this infection, as you tell, the clinical management. And now, because we are getting the more severe and moderately severe infection, and the gas gangrene and the necrotizing fasciitis commonly. The one thing which is important is to address the issue at the primary care level, I think. And because most of these patients got treated or management from the primary care physician. And if we are able to as you said, educate, give knowledge to the primary care physician, that at the initial level of infection, you need to treat it properly with a proper antibiotic, with a proper dose, and with a proper regimen. So that is the key for I think, in our part of the world, is to prevent such a nasty infection which can hamper the life as well as the food as well, or the leg. So thank you very much for highlighting such a as an important issue.
Thank you, Zaid. You're correct, Zaid. This we see all in Afro-Asia, Sub-Saharan Africa, and in Asia. I think what we are looking is just the cream where we are in the main city. Maybe Asia is much developed, but Africa is still more than 85-90% are still in a rural area, and we haven't reached there. And that's what we have started 35 years ago, and still growing. Now at least awareness has been created, and now the torch will be taken by other generation. Thank you, Zaid, for commenting that. Thank you. Shakavi hand is there.
Daniel, I think.
Harry, we can't hear you.
Oh, sorry. Okay, Daniel, I think I proceed. Then Shakavi after that.
Shakavi's hand is there. Maybe it's not, you can't see, it's a yellow background.
Yeah. Daniel is already finger up, hands up. Okay. Now mind. Daniel?
Yes, I totally agree with Abbas. One comment about diagnosis of osteomyelitis in my hospital. I am changing or treating I am changing the diagnosis of osteomyelitis. That not diagnosis is always MRI. Did you understand?
Yes, I understand. MRI, when we started writing the consensus 4 years back, and we released it on 14th of May 2023, we had a very strong discussion on MRI. It's not an easy thing to be done in a majority part of the world. Even my colleagues from United States, they also objected it that though you are in Africa, but we also cannot afford to prove osteomyelitis by MRI. And that's why that quote which I showed in that recommendation, they put there, that is not necessary to be done in each and every case. Only if you need to do it, because first is expensive and it's not accessible. So it's there in the international consensus. You don't have to really do it.
We have another tool.
Yeah. What, another tool?
Yes, we have a sausage tooth, MRI.
Yes.
Okay. Okay.
Yeah, I just did a research on 166 patients, just clinically diagnosing it, and then prove with an X-ray. You will hear in ESD if you attend that.
Thank you very much. It was a pleasure.
Thank you. Shakavi's hand is there. Unmute, Shakavi. That's why we cannot hear you. Unmute.
Yes. You can hear me now?
Yeah, we can hear.
Okay. Thank you very much for your historical educational lecture. Actually, it's very nice, very illustrative. I just want to add very small thing, if you permit me, the message that you are going to send for everybody. I would like to add for every physician who is going to treat deep-foot ulcer complicated or life-threatening, just to keep in mind in his examination sheet to find all the etiological factors for retarded wound healing. They are pointed 8 factors. They have to find out all these factors and then to make a plan of management, not to miss any one of them, not to be by my experience or something. No, they are fixed factors that have to be detected by everyone for every deep-foot ulcer retarded or complicated healing. Then, after starting the treatment, after 3 weeks or months or more, these etiological factors can be evolved again after correction, and he have to correct them again because of the delay of the time of healing. So he have to be conscious of these etiological factors and identified carefully and to be followed out through the whole journey of treatment. Thank you very much.
Thank you. I agree. Yeah.
I think from what Abbas has presented also, it depends on what modalities you have. So some people have got what they call it fluorescence devices, which they can check. And some people are doing the basic clinical assessment, just a probe test positive. And then they find there's osteomyelitis and all that. But I think one more section, I think, Abbas, is when you have osteomyelitis and at the same time, the patient has neuroischemic foot. That means also a peripheral arterial disease, basically, and it could be critical limb ischemia because of the infection, basically with thrombus and emboli and all these things, and the ABSIs could be below 0.5. That will be another super headache because, to get the blood flow in, to clear the infection, because before you can put a vascular stenting or even a bypass or whatever, you need to clear infection. If not, that stent will also fail. Just to pick your brain a bit, how would you proceed in that kind of a case? A patient who's got quite bad neuroischemic foot, because now we know that, when we were medical students, 35 years plus and all that, we used to talk about 10% only, but now it's already 40 to 50%. So, that's where, Shakawi cannot retire. He has to work till 100, basically, because we need the vascular surgeons because ischemia is becoming a big problem. So, Abbas, how would you proceed in that? I mean, what is your standard operating procedure or your clinical pathway or the pearls of wisdom from you, basically from sub-Saharan Africa?
Oh, I was going to say that last thing. If you look at the recommendation, it says that you need to get involved a general surgeon and a vascular surgeon. And the earlier you intervene by vascular surgeon, well, Shakavi would answer better than me. But in our case, because the vascular surgeons are not there, and our referral hospital has just started this year, and whenever you send this type of patient, they say that they have no accessibility to the small blood vessels. So in most of the cases in our part, we try to revive just manage it conventionally just like that. Otherwise, they end up with amputation. Or if they can travel, affordability, then we send them to India. But now it has already started this year. Hopefully, as we go, it is a heart institution which were very much working for past 10 years, bypass surgery and everything. And I was shouting, and then at last year, they said, yes, we are going to do that. And the people came from Apollo Hospital and USA and everywhere. And they said, okay, we'll help to invest and we'll start. So they have started. So this would be my approach.
Can I say-
Shakavi, you want to add? Yeah.
Yes.
Yeah.
I want to tell you something. Fortunately, when there is severe ischemia, 0.5 or less, there will never be infection because there is no blood supply to have the action of inflammation. And so usually inflammation appears when we revascularize the limb, then infection will flourish if we miss it. But with severe ischemia, usually there is no, to the extent that when we see pus in the foot, we are happy there is no severe ischemia.
Daniel?
Yes, the problem in Argentina is that not all the service have a vascular surgery. And the end of the patient will be amputations. This is a really problem, I think, around the world.
Yeah.
Yes. Same thing in Asia also, basically, because the major hospitals will have, but even then it depends whether they can actually go in to do the stenting or the bypass and all that. So otherwise, if you are in the peripheral areas and all that, even like one whole state, you might have only one vascular surgeon. If you look at Maldives, they have to send it over to India, basically, for vascular surgery. They don't have it in the country. Even Dr. Wahid is the first plastic surgeon of the country, basically. So you see, it's a bit of a problem. That's why we always say looking at low income, middle income countries or that, because most of these resources are very scarce. I mean, and when you see these cases, you don't have much to do. I mean, you're leaving it to God basically at times because they end up being amputated. And if they go to, let's say, the orthopedic side, they don't even go to the subspecialists for foot and ankle because not many of them. And when you look, sometimes it's just the general surgeons and some orthopedic surgeons who are doing it. So no podiatric surgeon also. So a lot of problems. I think it will take some time basically for us to actually get more of them. And hopefully keeping more in the public than going off to the private also. That's the other problem that we have also. Is there any other questions? I think, all right. If there's none, I think we've reached at the end of time. Dr. Salma, the president-elect, couldn't make it basically. So I will basically give the vote of thanks. So firstly, I would like to thank Professor Zulfiqar Abbas for doing a wonderful job. And it was fun basically looking at a clinical case, instead of just basically studies per se. And he covered quite extensively. And I would like to thank the board, basically, the Food International Board, the regional chairs, the advisory, and also all members of DFO International, as well as all the delegates. Thank you also to Ergo Foundation, which is our main corporate sponsor with Monlaka, and also the others like Oneness Bio before. And hope to see you for the next session and also the November meeting when we have the World Diabetic Day session. So with that, keep up the good work. And I think you all are doing a hell of a great job. And when you actually talk about real world evidence, you can see from your experiences that you all are trying your best to manage with minimal resources, minimal, what do you call this, funds, minimal specialities, trying to get a multi team approach, basically, as alluded to by Mike Edmonds for 40 over years. So, but this is something that I think it's a calling and we need to be passionate about it. So I think most of us will not be retiring. I think you can see quite a number of us here are losing hair, except Jolene, who still got full hair basically. So that means we will continue working for many, many years. And I think we need to do that. And as long as we are strong enough and all that, we should continue seeing patients and doing work. So with that, kudos to all of you and thank you very much and God bless.
Thank you.